Hello, and welcome to this session. This one is going to be co-hosted this time between myself, Taylor Heald Sargent, and my colleague at Lurie Children's, Daphna Magnetta. I'm a pediatric infectious disease physician that specializes in transplant infectious diseases, and Dr. Magnetta is one of my heart transplant colleagues. This session is also co-sponsored by the Pediatric Heart Transplant Society, which we are both members of. So today we're going to talk about understanding pneumocystis pneumonia. To set the stage, we have a little theme. Theme is the game of life. We understand that life is not a game, but sometimes it may feel like there are random forks in the road that can go one way or the other. And it can be confusing as to what leads you down each path. So we're hoping that this session will help demystify some of what we're thinking as medical professionals as you go down the road of your transplant journey. Today's going to follow this little boy. Please ignore the jumbled words. They don't mean anything. This is ChatGPT created. But we're going to be following him along his transplant journey down those branching points to see what happens and how we can help prevent him from getting a certain infection. And that infection that we're focusing on today is pneumocystis. So pneumocystis has a couple of names that right off the bat make it confusing. So it's currently known as Pneumocystis Jirovecii. It was formerly known as Pneumocystis carinii. It's abbreviated previously when it was carinii as PCP, which some of you might have heard about in past years. Now, I think more commonly people refer to it as PJP for Pneumocystis Jirovecii, and that's what we're going to be referring to it as today. And that refers specifically to the pneumonia, which is the most common thing that happens with this organism. So pneumocystis is a fungus. It only infects humans, not other vertebrates or mammals. So you're not going to be giving it to your dog at home if you have one. And almost all humans are infected with it, or at least acquire it, maybe not get sick from it, really early on in life. When they've looked at antibodies in people's blood, they've found that 85% of toddlers around age 2 already have evidence that their immune system has seen this fungus. So everyone gets exposed early on. It's all over the world. It's not one particular area. But it's not something that usually causes major disease in people with immune systems that are functioning well. So that's how it actually can be spread is people get this fungus. It can live in their nose, in their upper respiratory tract, and it can be passed from human to human. And then when you pass it from human to human, you might not even notice any symptoms. But if you do have a weakened immune system, it's what's known as an opportunistic infection. So it can cause infection in people with weak immune systems, such as kids with transplants. We know that kids with transplants are open to lots of different types of infections. So we wanted to explore a little bit why this pneumocystis or PJP is this special and why we're talking about it today.
Hi, I'm Dr. Daphna Magnetta. I am at Lurie Children's Hospital, and I'm a heart transplant cardiologist. And I'm going to talk a little bit about why patients who receive solid organ transplant are at risk for pneumocystis infections. And so really this goes back to immunology. And these are kind of complicated diagrams, but just to show first here on the left is how the immune system, or one part of the immune system, reacts when it sees something foreign. So in this case, and that's what we call an antigen, and in this case, it would be the pneumocystis infection. And so there are these cells called antigen-presenting cells that then trigger several arms of the immune system, often through these specialized T cells called CD4 cells. And they're called that because they have receptors on them that are called CD4, and that's how we can tell which ones are CD4 T cells by these flags they have on the outside of the cell. And then those CD4 cells are really important in activating different arms of the immune system. B cells that make antibodies against different infections, macrophages and killer T cells that go and try to get rid of the infected cells. And so this is basically what a normal immune system will do when it comes in contact with pneumocystis to try to get rid of the infection. And in an intact immune system, this is very effective. Now on the right is a close-up of one of these antigen-presenting cells as it's interacting with a T cell, and whether it be a CD4 T cell or a killer T cell or something like that, these interactions will be suppressed by the immune suppression that we give. So I'm going to point out, you'll probably recognize a lot of the medications on this list. ATG is another term for thymoglobulin, which is a medicine that we give at the time of transplant in order to really suppress the immune system. It's a powerful immune suppressing drug, and that blocks and actually completely eliminates, or we call depletes, a lot of the T cells that are in the body. And then other medications such as sirolimus, tacrolimus, MMF, which is Cellcept, azathioprine, steroids, act on subpathways in those cells or deeper within the cell to suppress the immune system, but not quite as strong as thymoglobulin. So as you can see here, because the immune system is lower and there's fewer T cells and fewer CD4 T cells in particular, patients who've had a transplant and patients particularly who receive thymoglobulin are at increased risk for pneumocystis infection. So how do we protect against it? We know this is a risk factor, and decades ago, more patients were getting infected with pneumocystis. So we learned that there are quite effective antimicrobials to treat this. And the most common one is Bactrim. A lot of you are probably familiar with this Bactrim. It can be in a solution, and then when you're big enough to swallow pills, it can be in a very large pill that a lot of kids don't like. But this is something that is very effective at treating pneumocystis, but also at lower doses at preventing the infection. It's about 85% effective at least. For some patients, they have allergies to Bactrim or they can't have it for whatever reason. And so there are other medications that we can use to try to suppress pneumocystis. The most common other one is pentamidine, which can be given in different forms, but most commonly is an IV infusion once a month. And so that's something that several of our patients will also get if they can't tolerate Bactrim for reasons I'll explain next. And then less common would be other pills called like dapsone or atovaquone. The other thing you can do is reduce immunosuppression. So in patients who've received thymoglobulin already, you can't undo the fact that they received it, and they are at risk for 3 to 6 months. Their T cells can be pretty suppressed after that. But in patients who are on long-term immune suppression, you can try to reduce that to try to prevent infection. So then another question that comes up frequently and is actually something of interest to our committees in the PHTS group are how long should we use prophylaxis? So I've mentioned the highest risk of pneumocystis infection is in the first 6 months post-transplant, and that is a lot of times because a lot of patients have received induction immunosuppression, which is thymoglobulin or a similar medication, but also just levels of immunosuppression, even in patients who don't receive induction, are higher in the first few months. And that's because the risk of rejection is highest in the first 3 to 6 months or so post-transplant. And so when people want to protect against pneumocystis, a lot of times people are kind of thinking about that 6-month window. But, there's not a ton of data. Pneumocystis is fortunately a pretty rare infection. In some studies, it's been about 1% of patients that get it in the current era of using prophylaxis or prevention medicines. But there is a little bit of data. So in 2019, there was a survey from the International Pediatric Transplant Association. And, as a heart cardiologist, I was interested in how many of those were represented for heart transplant, but it was a nice mixture of different types of transplant. And about 88% utilized some form of prophylaxis. One of those medicines I mentioned for some amount of time. But the amount of time that they used it was variable. Some would use it for, 3 months, some would use it for 12 months. But most commonly it was about 4 to 6 months. And I think that's based on an understanding that that's when the degree of immunosuppression is the highest. And then it was not uncommon for people to have to resume prophylaxis even when it had been stopped. So about 68% felt the need to resume it at a later time. And I can, go into reasons you would do that. But the most common reason is the immunosuppression had to be increased for whatever reason. Perhaps there was some rejection, and then they would feel the need to resume Bactrim prophylaxis to prevent pneumocystis. This is something we were interested in the PHTS Standardizing Care Committee, as it's something that is, as we said, highly variable, and with more standardization, we hope to be able to better study outcomes and try to refine this, because we feel that certain patients, some patients may need more prophylaxis, some may need less. Just like immunosuppression, this should be something that's tailored to each patient. But we just don't have a good enough understanding of how to make that precise determination. And so this is something we're hoping to study a little bit more. We did a quick survey of centers and found similarly there was a lot of variability. Most people actually were stopping prophylaxis after about 6 months. I'll tell you, at Lurie, we use it longer, closer to a year, or even longer in some circumstances. But most people also could recall a case of pneumocystis. So it wasn't so rare that people weren't seeing this infection anymore. And often when it did happen, it was off of prophylaxis. So once they had come off. So the prophylaxis is quite effective. And then this is also reflected in the guidelines. In 2023, ISHLT put out some updated guidelines for management of heart transplant recipients. So again, this is specific to heart, but you can see here that in 2010, there was a suggestion to institute prophylaxis for anywhere from 3 to 24 months, so pretty wide range there. And then now the suggestions have been narrowed a bit to anywhere from 6 to 12 months, but still there's not strong evidence for this, and it's something that's highly variable. So sometimes we can't stick to our protocol and we have to deviate. So there are several reasons you may need to stop prophylaxis, and sometimes there are reasons you need to resume it when you had already stopped it. So the most common reasons that I could think of for why we stop prophylaxis, an obvious one is allergic reaction. If you're allergic to the medication, then you can't continue it. Usually, fortunately, we have a few options now and we can transition from one to the other. But that may be a reason we would consider the risk benefits of continuing or trying to pre-medicate with things like steroids and antihistamines to try to get through the high risk period. Oftentimes, even so early after transplant, we can see not just the lymphocyte count or the T cells go down, but we can also see other cell lines like neutrophils and platelets get affected by the immune suppression, just because all of the cells are not being made as robustly as they were before the immune system was suppressed. And so those may be reasons that we would have to back off on the immunosuppression, because some of the medicines like Bactrim can also cause those things to go down. And so that may be a situation where we have to back off on prophylaxis. We can also see injury to the liver, injury to the kidney. That's pretty rare, but it has been seen. And then another reason we may need to either switch or come off of prophylaxis, or elevated potassium level. That's something I've seen a handful of times and gets better after coming off of the prophylaxis. And then reasons we may need to restart. The most common reason would be that there's an episode of rejection, usually a pretty severe rejection, where we need to give another dose of an induction agent like thymoglobulin, and then we would pretty much restart the clock and resume prophylaxis. So that's the most common reason. And then it's usually whatever the protocol is for that institution for how long it's resumed. In some patients, we monitor things like CD4 count, so how many of those CD4 T cells are circulating in the blood. And if it's very low, we're worried about their general risk of infection, but particularly of opportunistic infections like PJP, and we may resume prophylaxis. And then obviously, if there is a PJP infection, we're worried about the future risk for infections. We'll try to think of the risk factors and reduce those, but it may be a patient that needs to stay on prophylaxis longer after their treatment course. And I'll turn it back over to Taylor.
Thanks, Daphna. So I want to take us back to our transplant kiddo. He's doing great after transplant. He's marching down his journey. He had a little bump in the road where he had some rejection, went briefly back on Bactrim prophylaxis when he had increased immunosuppression, but is now off of the Bactrim prophylaxis and living his best life. Of course, this is a talk about infections, so he eventually gets the infection. What does it look like? Well, he develops a cough and a fever, which might sound familiar to you if you've ever met a child or really ever had a cold yourself. So when would you want to worry? Is this cough and fever something more? Is this something I need to worry about? And obviously, this is a very general talk. We're not providing specific medical guidance. We recommend that you talk to your transplant teams. But usually your transplant team would say either come into our clinic for evaluation after a certain point, or they recommend that you go see your local primary care physician, your pediatrician, or your local clinic. So when you go into that clinic, there's a few things that might help them in their decision about which path to proceed down. Do we think this might be PJP? Interestingly, physical exam isn't one of them that's as helpful because the lungs might sound okay, even for being infected with a fungus. What can help us is measuring an oxygen level in clinic, which is something you can do just in clinic with that pulse oximetry on the finger. And a big sign of PJP is actually having reduced oxygen levels, also known as hypoxia. Another thing that can be helpful is if you get a chest x-ray, and here on the slide, there's 3 different chest x-rays of patients with PJP. And though they look different, something that you might notice across all 3 is that they look kind of fluffy. They have what we call diffuse infiltrates. So there's not one particular area that looks like there's an infection. It's kind of all over. There's evidence of white or opacities. And that's a clue that this could be PJP. So armed with those clues, with the oxygen levels and maybe an x-ray, your doctor or your transplant center might keep going. They might go and decide we want further proof or further evidence and get more imaging. This is a chest CT of a patient with pneumocystis. So their x-ray is the one on the top. So that's the one that has the fluffiness throughout. And this is an example of what it looks like actually when you look at more slices of the lungs. So if you can see this top x-ray here, get the pointer. This top x-ray here has kind of fluffiness throughout. If you were to take a slice across the middle of the patient's chest as they're lying down, that would be this image here. And whiteness, you don't want to see whiteness, you want to see darkness because darkness is the air. So here's areas where it's filled with fluid or inflammation and the air isn't able to get across. This image kind of looks like the x-ray, but it's just one slice. And again, you can see all of the bright areas. And that explains why the oxygen levels might be low, because the oxygen's not able to diffuse and get into the body when you have all of that inflammation. So armed with those, your physician might start talking to an infectious disease physician. They're friendly ID team. So that's me. And if there's enough evidence, we might actually recommend specific testing for PJP. Now I'll say, although there's some great tests for PJP, it can be hard to really do these. Starting with the easiest one, and that's the beta-D glucan assay or Fungital. It's something that we do Not infrequently, but it's also really nonspecific. It's a blood test, which is great. So you can do that just from your clinic. But when you get it back, you can't always tell, is this PJP or not? Because it could have evidence of lots of different fungus. But if it's really, really high and the other signs point to PJP, we might decide that that's convincing enough. If it's really low, it might make us think this is definitely not PJP. The best way to actually figure it out is to do a sample of the respiratory tract secretions themselves. So that might require that the little guy undergo a bronchoscopy. And usually with children, this involves putting them to sleep under anesthesia and then putting a tube down their throat with a camera attached, flushing a little bit of fluid into the lungs and then taking that fluid out. From that fluid, we can actually look for the organisms directly. We can stain them in the microbiology lab and look by direct fluorescence assay or DFA for the bugs. And then if you see them there, that might give you your answer, again, if the symptoms match. We can also do a DNA test. So look by polymerase chain reaction or PCR to see if there's the DNA of PJP in the lungs. This one is a very, very sensitive test. So it can be a bit tricky to interpret because, as we said, a lot of people can have PJP and it not be causing an issue in them. It's just being mild. And so we might want to have like a lot of other signs, such as that Fungitella along with it, to make us think that that PCR positivity is indicative of PJP, or if you have all of the classic symptoms. So thinking along down our path, if all of our decision points are lining up and making us think this might be PJP, the next step would be treatment. As Dr. Magnetta already mentioned, the first line treatment is the same as we do for prophylaxis, Bactrim or prim sulfamethoxazole. It is extremely effective in treating PJP. So it's very nice for us. It might be hard to diagnose this and figure it out, but once we do, we can treat it. So we start Bactrim, and sometimes if the immune inflammation is high enough and the patient's sick, then we also give steroids. So I mentioned that sometimes patients just present with a fever and a cough. And while this cough might be lingering for some time, sometimes patients are rapid and they get really sick really fast. So depending on that is when we might decide to do steroids or not. Now, because this is a fungus and it takes a longer time to grow, like most fungal infections, we treat this for a long period of time, on the order of weeks. And then we usually put patients back on prophylaxis, since they've shown that they're at risk for this infection. But the good news is that once we are able to figure out what's going on, do the correct diagnostics, and start our treatment, we can usually get the little guy feeling better and back on to his normal, happy transplant journey. So with that, we'd like to pause and take any of your questions. If you want to put them in the chat, we're happy to answer them, or we'll be sticking around for a few minutes live if we have some time. Thanks so much for letting us join you today.
So I appreciate everybody joining this session on PJP. It's personal to me as a heart transplant parent. My son is a 13-year-old heart transplant recipient. We are seen at Lurie Children's Hospital, which happens to be the center of that both of our presenters are from. And that's not entirely a coincidence, because last year in January, he was inpatient at Lurie for 1 month after he was diagnosed with PJP. The feeling is that he'd had it for some time before. So both of the practitioners here were instrumental, and I'll be honest, they saved his life as part of the team. And so they use the therapies that some of the therapies that they discussed. So with that said, I would like to ask Dr. Hield Sargent, who's here, to answer some of the questions. Unfortunately, Dr. Magnetta fell ill right before the session, but as you can see, we were still able to deliver that to you. So Dr. Hield Sargent will be able to kindly answer some of the questions live. So I see we have a number in the chat. Taylor, do you want to read them off directly, or do you want me to read them to you?
Yeah, I can read some. I've been reading through them as we've been going. Thank you all for joining us. And thank you, Joseph, for introducing us. So the thing about the question that says how it might present differently in older and younger individuals, historically, this infection was seen in weak infants that had a lot of medical comorbidities, and I'm talking a long time ago. And in those infants, it could sometimes present over longer periods of time where they just weren't doing very well. Then when you had the AIDS epidemic in the late 80s, early 90s with patients with severe immunosuppression, we were seeing many, many more cases of PJP. And in the older individuals, it could sometimes progress more rapidly. My experience is that it can actually be more varied even than that. And I think that this is a ripe area for investigation in the transplant population, especially the pediatric transplant population, is just how does it present? Because sometimes it seems like it's a more mild indolent where it goes slow and someone just has had this annoying cough and they come in and we notice that their oxygen levels are low. But then I have seen some children come in quite sick. And it's like any other pneumonia infection where we need to act rapidly and figure out what's going on. So it was thought that there was a discrepancy, and that's what the textbooks would tell you. But I think that we could still use a little bit more evidence to clarify that. Crucial warning signs to contact your transplant team. I'd say with any infection, reach out to them if you think your child has an infection. They will do their best, educated, hypothesis differential to try to see what they think they're treating. Usually the most common thing would be either a viral pneumonia or a bacterial pneumonia. So they might say, this should get better over the next few days. If it's a viral pneumonia, there's not anything that will necessarily give. There's bacterial pneumonia, they might try you on an antibiotic. If your child is not responding or you are not responding to that therapy like it would be expected, which is slow improvements day by day, reach out again. And then let us reassess and take a look at our differential or our list of diagnosis as it could be, and look at your oxygen levels in clinic again. And then that would be what I would say, is just reach out to us if it's not going the way we told you we'd expect, which is improvement with our therapies. And then someone asked about prophylaxis for everyone. And yes, Bactrim is the first line prophylaxis. It's not typically used in patients that are very young, but usually our transplant patients are not that young. They're not less than 2 months old on average, maybe in very rare circumstances. So yes, Bactrim is usually used for most patients, at least for some period of time. As Dr. Magnetta mentioned, the time it varies, and that's another area that is open for research and standardization to see exactly how long we would need it after after solid organ transplant. And there was another question about, since Bactrim does work so well, why don't we just give it forever? And some patients, if they're high enough risk, and in adults, that's what sometimes is said, is if you are at high risk forever, give it forever. And there's other conditions, like other patients with immunodeficiencies, where they might be on prophylaxis with Bactrim for years. Some patients, they might not tolerate it. They might have some of those side effects that Dr. Magnetta mentioned, and that might be where you go into second line options if you really need the prophylaxis, such as pentamidine, although those don't always work quite as well. But other reasons, if you have just patients that maybe aren't tolerating it for other reasons, it could be the pills are big. And so older patients that are on the pills don't like it. And I actually just had a patient who is a toddler, and her mom was saying she just has really started not liking this one medicine and the liquid. And it's just, I'm sure many of you have experienced it. If a toddler does not like a medicine, it's impossible to get it into them. So then we have to think of workarounds. And that's why it's really important for us to figure out, how long do we need it? How long do we try to keep patients on it? And if people are tolerating it and doing well, we might keep them for longer, but we don't want to keep them on anything forever if we can avoid it, not just because of the side effects and the intolerance, but also we don't want patients to have too much of a pill burden and to get frustrated with it, especially as they're entering their teen years. We know that could be an issue. Okay, let me see. So someone else asked, beside medications, any other steps you can do to prevent it in a family outbreak? It's not really anything that you can do to prevent. It's something that's around us all. And it's ubiquitous, meaning it's everywhere. There's nothing we can do. It's actually how it's transmitted is really difficult to figure out. And we found that it can go from person to person, actually looking at outbreaks between immunocompromised and between cystic fibrosis patients. And that's why we know that it's important to practice good infection prevention controls when you get larger groups of immunocompromised patients around each other. But from family members that might be healthy and showing no signs of infection, it's really going to be hard to figure out if you have even been exposed or infected because you won't show any signs. So practice your normal good hand washing if you're not feeling well, trying to wear a mask or staying away from directly coughing on individuals. And if you're not coughing, the chances of spreading hopefully are lower because you're not actually expelling any of the particles. And then sulfamethoxazole is nephrotoxic. So that's not necessarily true. And maybe it's a different medication. There are a lot of sulfonamide antibiotics and different medications that could be, but trimethoprim sulfamethoxazole is what's used, is called Bactrim, and we do use that in our kidney transplant patients. But I'm seeing from the chat that I think I'm out of time. If you have any other questions, feel free to reach out through the conference organizers, and I'd be happy to answer them. Thanks for joining us.